executive plastic surgery. So another Facebook Live, you will learn from this case as well. And again, the whole goal here is into teaching. 11525, initials RH. Nice patient from California, very nice case. So she had what was left breast cancer. So she ended up getting mastectomy and reconstruction, a total of 3 sets on the left side. In 2008, she had a tissue expander, and we're not sure if she had the allodrome, which is cadaveric skin. And then she had what was lymph node 6 removed, and she had what was lymphatic fluid that built up. And in 2009, she had a replacement, and then another surgery in 2022, her 3rd set. On the right side, she is being treated as a cosmetic patient, so she has her own native tissue. And so she ended up getting 2 sets, one in 2008, and this was below the muscle, and in 2022 above the muscle. So the goal today was to remove what is the right inframuscular residual capsule scar tissue, which is what I did right here. And this is the non-cancer side, the cosmetic side. This is the side I did first. And as you will see, if I cut this open, you will see that this is indeed what is, a residual capsule. You can see the pocket on the inside, and this will be indeed sent separately to pathology. You can see how much it shrivels and shrinks. The right side, this is the implant capsule. You can see how it's sitting. All inflamed tissue removed, and you can see some areas so thin, some areas relatively thick. I removed all of that inflamed tissue. I just want to go ahead and show this tissue right here at the bottom. As I cut open, there was suture that was seen. Look how thick this tissue is. As you can see right here, it's like a band. I had to remove all of this so that the patient would have all of the scar tissue removed. Look how thick this is. I'm having a difficult time just cutting through it. And remember, anything abnormal that feels abnormal, palpates abnormal, I remove, because that is inflamed tissue. So as I go in here, remember, this cannot be ruptured because this is just from 2022. So the goal here is to remove all of that scar tissue. This is done in the En Bloc fashion. Remember, this is so thin I can pass my scissors through, and you can see how thin it is. You can see, let me actually go ahead and get this to show how thin this capsule can be. Now, no matter how thin the capsule, in my practice, I remove it completely, so that this En Bloc is done. God forbid there was fluid on the inside. All of this was going to be removed. When I hear some surgeons say that it was so thin I left the capsule behind, not a good technique in my practice. And so as I cut this open, intact implant, what I would say, look at the way how it's compressed. See, so small amount of fluid on the inside. You see how it's compressed? Now let me go ahead and try to cut it out so you can see. So she has what is a capsular contracture on this side. You can see how it's sitting bunched up on itself. And you can see again, look how thin this capsular tissue is. Remember, the surgery is all about precision and not about speed. And as I go in, there's some fluid around. You can see that stickiness. This is your gel bleed. This is your Mentor 340cc implant. And what I would say, brand new condition. And as you will see right here, you have relatively very thin capsular tissue. And overall, I'm very happy, content with how the whole dissection has gone. So the right side was treated as a cosmetic patient. Now the left side, we will see. Now what's interesting is there is no mastectomy flap, because this was a tension-free closure. The skin came together very well. She had good quality skin. She had a lot of scar tissue on the left lateral underneath the armpit that I removed. This was certainly abnormal. If you look at it, it's thickened. You can see how it looks. As I cut through it, you will be able to get a good understanding as to what it is. And so I'm going to send this scar tissue because of the pain that she had. And you can see right here, I'm overall very happy with how the whole dissection has gone. And you can see some areas relatively thick. I put an X where I saw some suture. This was literally anchored onto what was the scar side. and causing a lot of hurt for the patient. So we're going to see it from the inside, and she very likely has suggestions of what is alloderm. So actually go in from here. You see this is the back side. You can see the indentation right here. So I'm going to go in. Look at how thick the scar tissue is. All of this tissue needs to go. Go it from here. There we go. So as I go in, I purposely chose this side. You can see this is very thick. You see that white band? This is a rectangular alloderm that's placed in the reconstruction. So I'm going to go ahead and remember this is the cancer side. This is the one I operated on second. And then as I remove, look at this intact implant from 2022 left breast cancer. And this is your 500 cc implant. And as you can see, it's in new condition. And what I'm going to do is I'm going to go in and I'm going to invert this tissue. So this is alloderm. Very good amounts of it, lots of it. And you can see on the inside, look how they sutured. Look, you have a knot right here, and you can imagine, look, this knot. I don't like to see this, especially when it's going to be rubbing against this sensitive implant. And as you can see, this alloderm was sutured together to itself. It's a lot of this is cadaveric skin from another patient that was processed. You can actually even see the hair follicle areas where the hair comes out from on the skin. And this is a lot of alloderm. The alloderm is the whole capsule, if you will. Extensive amounts of it. So you can see this rectangular band right here. So all of this is your... Now this is a technique. What they do is they suture the whole alloderm around. It's well published, but you can see all this proline suture that was used and visible for me as I was dissecting. So it was important for me to remove all of this foreign material. You can see this is the alloderm. I'm going to go ahead and see if I can tease this off. Very thick. If I try to tear it with my hand, I cannot. And even if I try to cut it with my scissor, I'll tell you, my scissor is bending. You can see it's not going to be able to cut it. It's like a leather bottle, if you will. So you can see extensive amounts of this proline suture. So I am going to go ahead and the implants will be returned to the patient. Capsules will be sent right and left to pathology, rule out the BILCL. Right intramuscular residual capsule scar tissue will be sent separately, and that scar tissue I'm going to send separately. So I'm going to have a total of 4 specimens to send to pathology. History of breast cancer on the left side. And then I'm going to take cultures for aerobic, anaerobic, and fungal, and most importantly, we'll see how the patient bounces back to a normal state of good health minus these toxins. She had a very bad experience with these reconstructions over the years, and she was telling me that she's very happy to get this overall behind her after the surgery. So again, the goal here is this nice patient from California did her homework. She's going to do it once. She's going to do it definitively, completely, sincerely, and all that was removed was tested, and she's going to have the pictures and the videos of the chest wall showing complete removal of this scar tissue, residual capsule, alloderm, suture material, so that the scar doesn't bother her and that she has freedom from what is the silicone toxicity. This is Dr. Khan, Executive Plastic Surgery. I have never seen this much alloderm. But you know there is a technique.